Hi dear friends, this is Dr. Rajiv Karnik, cardiologist from Mumbai. This is a special bulletin because in between there was lot of confusion in the minds of our patients regarding cholesterol diet, cholesterol treatment, and then whatever that we had learned and whatever that we were preaching and practicing came into a big cloud. Because there was some authorities which were saying the diet is not important at all. The statins, maybe they produce more harm than benefit, and then there was a lot of confusion. So that's why this is a special bulletin just to clarify what Lipid Association of India has to say. Firstly, in India, coronary artery disease is on the top of the world, and India is leading as far as the prevalence and the mortality rate with coronary heart disease is counted. In the last century, beginning of last century, it was thought that coronary artery disease is a disease of affluence and only the well-developed westernized countries would have it. But then from 1960s, 70s and 90s, it was seen that Indians are in fact more prone to develop coronary artery disease. And then whether Indians stay in India or whether they go to England, America, Trinidad, Singapore, from different parts of the world, it was shown that Indians have high prevalence of coronary artery disease. It's not only that they have higher incidence and prevalence, but it occurs 10 years earlier as compared to the Western counterparts. Moreover, it is more aggressive. The triple vessel disease and left main disease, which is a more malignant form of coronary artery disease, which is more prevalent in Indians, and Indians die earlier, they develop heart attack almost 10 years earlier, and then in fact we have in people in 20s and 30s, many of them who have either sustained heart attack or they have undergone angioplasty or bypass surgery. So enough to say that we are different, our genetic predisposition is more. And then if you see the various risk factors for developing heart attack, then there are very many, but then recently the Inter-Heart study, which was conducted in 52 countries, and then of course India, Sri Lanka and Bangladesh were also included, Asian countries were included in this Inter-Heart study. It was seen that 90% of the heart attacks can be predicted with simple 9 risk factors, and the topmost out of this 9 was the lipid as a risk factor. So keep in mind, lipid is not an entity to be ignored, and there should be no cloud about its existence as a risk factor and about its treatment. That is the second point that I wanted to emphasize. Now, when it comes to the treatment of dyslipidemia with diet, exercise and medication, then of course the first and foremost, there is no excuse, and then one should not say that he will take medicine and he will forget about lifestyle change, exercise, dietary precaution. The diet, lifestyle changes comes first, and then the next is of course medication, medical treatment. And amongst the medicine over a period of last half a century and then this in the present decade, 15 years, the various medications have been tried. But what is the ace medication? And that is statin. The statin as a lipid treatment has proven beyond doubts unequivocally it is number one therapy for lipid in terms of reducing or correcting lipid abnormalities, in preventing coronary artery disease and preventing the acute events such as heart attack and death. Not only in the heart but even in the brain, the stroke. All these acute events are extremely well prevented with statins, and there is no alternative to statin. There is another medication which has come up which has again proven to be effective as an adjuvant to statin, and that is ezetimibe. And in addition to statins, of course we have other old medicines like resins and the new upcoming medication like PCSK9, but then currently as on today in Indian practice I would emphasize it is statin, statin and statin for the treatment of lipids. So let us first discuss statins, how the statins work. Basically, LDL cholesterol is the worst offending lipid molecule which accumulates in the subendothelial region of the vessels, namely the coronary arteries, cerebral vasculature, renal arteries, peripheral arteries, and it starts producing blockages. So, when you want to reduce LDL, it has to be removed from circulation, and that is done by liver. So, statins work at the hepatic level. They prevent an enzyme called as HMG coenzyme A reductase, which interferes with the synthesis of cholesterol. The liver becomes deficient in LDL cholesterol. Because liver needs LDL cholesterol to form bile, it starts extracting more and more LDL cholesterol from the circulating blood by trapping LDL cholesterol from blood by the receptors which are called as LDL receptors. So statins upregulate the number of LDL receptors, and with more number of LDL receptors, more LDL is trapped from the circulation, removed from circulation, and then the LDL level in the blood starts going down, and then that is what we say the LDL reduction of 35%, 40%, 50%, which is achieved by statin, which in turn results into the clinical benefit in preventing heart attack and stroke rates. Similarly, there is another molecule that is coming up and which I think will be very promising, and that is PCSK9 inhibitor. Now, I talked about LDL receptor which traps the LDL from circulation, but these LDL receptors are destroyed by PCSK9, and it is PCSK9, if it is deficient genetically by mutation, then these are the people, the luckiest people, who do not have the destruction of LDL receptor by PCSK9. They have more number of LDL receptors, more trapping of LDL, and less LDL in the circulation. But in a normal population, in where we don't have this mutation, so what we can do is we give injectable monoclonal antibody which destroys PCSK9, so which in turn prevents the destruction of LDL receptors, and then this is the way to keep the upregulated or more number of LDL receptors on the hepatic surface, which will trap more and more LDL from circulation and will remove LDL from the blood circulation to reduce the LDL reduction, which will lead to the clinical benefit. And then of course, apart from these two molecules, we have other traditional treatment like ezetimibe 10 milligram a day, and then of course the resins, lifestyle changes, dietary precautions, which I talked about earlier. Now let us come to the endeavor of Lipid Association of India. Why they needed this? In fact, you will remember that there was a lot of ill propaganda about statin and even the cholesterol rich diet, and there was a misinterpretation because of the various publication in the media, and patients, they were doubting about this diet, and then statins, and then the very important molecule statin which we are discussing today was underrepresented and then in the minds of patients as a good therapeutic agent. So knowing that this important medication may not be used adequately, what Lipid Association of India did, they conducted series of meetings all over the country. There were 30 cities which were involved. There were 153 key opinion leaders, the doctors, including cardiologists, internists, endocrinologists, nephrologists, and so on and so forth from different faculties. The doctors gathered either together or on web conferences, and then they gleaned the literature, they went through the multiple publication, and then finally they formulated some conclusions out of the scientific data, not just based on one report which may be adverse and which may doubt our these previous concepts which have come over last century. And then what was concluded? Yes, the conclusion was lipid is still number one in production of atherosclerotic disease, and an atherosclerotic disease being the foremost killer of the mankind at present, we have to take care of lipids. Amongst the lipid treatment, statin treatment stands as a ace treatment, and the non-statin treatment is always in the background as a supplementary treatment if the statins are either contraindicated or not adequate. Amongst the statins, we have to produce certain degree of LDL reduction. Just merely taking statin 5 milligram, 10 milligram is not sufficient. You should know the number, what LDL cholesterol you have, and then what is the percentage reduction in the LDL cholesterol that has been achieved. Previously, we used to talk about the goal of LDL cholesterol. If it is more than 190, start the treatment. In secondary prevention, bring it below 100, preferably below 70 milligram percent. But nowadays, there are some people in which we find that basically the cholesterol itself, in the beginning of the heart attack, it may be just 100. So then it is the percentage reduction in the LDL cholesterol which is important. And then more than 50% reduction in the LDL cholesterol, I think, which is what one should aim for, especially in the first aggressive step. The aggressive reduction and the high dose statin, that should be given in the initial period after acute coronary syndrome, may it be heart attack, may it be non-STEMI, or may it be a stroke. Especially in the first 8 weeks, high dose statin is very important, because statins not only they reduce LDL cholesterol, but they have lot of pleiotropic effects, because there were some trials like Miracle trial, Prove It 22 trial, in which it was seen that even before the LDL reduction could occur, in the matter of just first 4 weeks time, first 1 month's period, there was a separation of the mortality or the event curve when the statistical analysis of Kaplan-Meier curve was done in terms of survival. And that was not because of LDL reduction. So this particular phase was what is called as the pleiotropic effect, or the extra benefit of statin, which is beyond LDL reduction. And then there are various theories behind these pleiotropic effects, the mechanisms which are postulated, that this isoprenylation, which is inhibited by the statins, and it is the isoprenylation which takes very pivotal step in the inflammation of the atherosclerotic plaque and its inflammation, and then vulnerable plaque formation and its rupture, and acute coronary syndrome, heart attack or stroke, which can be prevented by this preventing isoprenylation. It also has beneficial action on the endothelium. The endothelium, which prevents the vaso-relaxing factors, then it prevents the vasoconstrictive factors, it prevents the platelet aggregation. It also works in the subintimal region where the smooth muscle cell migration occurs, the development of oxidized LDL and its engulfment by the polymorphonuclear cell or the phagocytes, which leads to the destruction and then inflammation in the atherosclerotic plaque, that is prevented. The production of matrix metalloproteinases, which comes in the inflamed plaque, and it is the matrix metalloproteinase which ruptures or breaks the capsule of the atherosclerotic plaque, and it is the ruptured plaque which becomes the initial event in the acute coronary syndrome, which leads to the thrombus formation, heart attack or stroke, and which is basically because of this rupture, the plaque rupture or the capsule interruption by this matrix metalloproteinases, and that is also prevented by statin. So in short, there are various multiple pleiotropic mechanisms through which statins work. And then that's why statins have remained number one in the treatment of this atherosclerotic cardiovascular disease, in its management, in preventing acute event, as well as the prevention of progression of atherosclerotic disease. Now, as regards the statin dosage, Lipid Association of India has emphasized, similar to European Society, similar to American Heart Association and American College of Cardiology, the high intensity statin and then the moderate intensity statin. The statin in high dose means rosuvastatin, atorvastatin. Rosuvastatin 40 milligram, atorvastatin 80 milligram. We can go to 20 to 40 of rosuvastatin and 40 to 80 of atorvastatin in this group as well, depending upon the sensitivity of the person in terms of LDL reduction. And this dose is essential for this early reduction in the mortality, event rate, and this separation of the Kaplan-Meier curve, which I was highlighting earlier, which was seen in the miracle trial in the acute coronary syndrome. And what is moderate intensity statin? It is half the dose. So 10 to 20 milligram of rosuvastatin, 20 to 40 milligram of simvastatin or atorvastatin. In this moderate intensity, even pitavastatin and pravastatin is also included, but these two molecules are less often practiced in India. So we still, I think we should emphasize on rosuvastatin, atorvastatin, and to some extent simvastatin. And dosage should be remembered that it is not mere 5 milligram and 10 milligram, which many of our Indian patients try to scale down. We should give the proper dosage which are emphasized by Lipid Association of India. And it is not just 1 month or 2 months treatment, it should be a lifelong commitment for prevention of atherosclerotic cardiovascular disease.